All right, good morning, everyone. We're going to get started. We have a good group, and we have a lot of information to go over that I hope to share with everyone. And I'll do my best to explain things as thoroughly as I can as we go along. Afterwards, there will definitely be time for questions. We'll have plenty of time for people to ask questions. So if you have anything in mind, just write it down and I'll address it. First of all, also thank you very much for coming, and also thank you very much for having us and allowing me to come and us to come and present. The last year, 2018, and throughout beginning of 2019 have been really interesting and exciting in the field of cardiology, and specifically in the field of prevention. So this is something that's very important to keep in mind, and I'll reiterate this as I talk, is we're talking about preventative cardiology. We're talking about medicines that would be potentially useful before a person develops significant heart disease. It's also, some of this also applies for people with heart disease. As always, this is, I'm presenting general information, and people's specific medical needs are different. So I don't want people to, change the medicines they're taking or not take certain medicines just because of the information that I present. But what I hope to share with you is interesting science that's been published over the last half year that I think will really change the way we do medicine, the way we practice medicine. I'm going to talk about aspirin because that's really been a big change that many people have been talking about and writing about, and you may have read and heard your doctors talk about it. I'm also going to talk about fish oil and vitamin D. These are things that people often take, that people know a little bit about, but I think it will be useful for us to really spend some time understanding and learning more. Aspirin has been around with us as humans for thousands of years. This is not a new invention. We've been doing and giving people aspirin literally for thousands of years. So the Ebers Papyrus, an Egyptian medical text from over 2,500 years ago, already describes the potential uses of the willow. And the willow, as I'll share with you, that's what aspirin is derived from. And so thousands of years ago, the Egyptians knew that sucking on this willow bark may have potential uses in reducing fevers and reducing pain. Then about almost 200 years ago, a Swiss pharmacist discovered that he was able to extract some of this, a certain substance from meadowsweet or Spirea ulmaria. This is the same thing as willow bark. It's genus and same species. And so that was the beginning in the modern era of kind of getting aspirin in really high potent forms and beginning to apply it to humans and to a wider population as a real medical treatment. In 1899 is when aspirin really came to the market with Bayer patenting the compound and giving it the name that we are now calling aspirin. A stands for acetyl. That's the chemical compound that is part of aspirin. Spire, S-P-I-R, that comes from the name for the name of the actual plant, as I shared with you, where the medicine comes from. The plant Spirea ulmaria, which yields the salicin acid. And IN was an ending that often was added to other roots to make the word sound like a quote real medicine. And so that's how we came with the name aspirin. And so this is one of the early bottles of how aspirin was given to patients. Aspirin really started being used as early as the early 1900s. By the middle 1950s, 60s, 70s, it was really in widespread use throughout the medical community for fevers, for pain, and then there were several trials throughout the 80s and early 90s that said, hey, this is a medicine that has some potential to prevent heart attacks, to prevent strokes. And so that's how it came to be that for decades, the medicine was widely prescribed. The person would come to the doctor, to the doctor, would say that, hey, I'm getting older, I have diabetes, I have hypertension, I'm at significant risk of developing heart disease. And then the doctor would go on to prescribe the aspirin. And so for many years, we thought of it as a very kind of a great tool. We thought of it as relatively low risk. Everyone innately, or a lot of us in the medical community innately understood that, hey, this is can often act as a blood thinner, and there's some people that develop bleeding because of the mechanical or because of the chemical action of the medicine. But we thought, hey, the benefits outweigh the potential risk, and so the medicine was prescribed widely. I'm going to try to share kind of real, actual medical literature without making it too complicated and too burdensome. But the studies that I'm showing you and what I'm sharing with you is the actual published science. It's not another newspaper's take on it or editorial. This is the actual data. So sometimes that gets a little bit burdensome, but I'll do my best to explain it. There's several ways in which, in the medical community, in which we decide and in which we share data and in which we publish new data. There's different types of trials and different types of publications. Very often in the news you may hear the words meta-analysis. So what does the word meta-analysis mean? Meta-analysis means that this is a person or a group of scientists that have analyzed a group of studies together. So they say, hey, someone studied older people in Europe, and someone studied them in America, and someone in Europe. Let's combine all of this data together and hopefully have a meaningful result. And sometimes that offers us very useful insight into a specific question, but sometimes it actually creates faulty information because it may lead us astray because the outcome that we get is dependent on the input, is dependent on the individual trials. Not all trials are the same, not all patients are the same. So it's a mixed bag. It's a mixed idea sometimes. And then in medical literature, there's also various medical journals. There's literally thousands of medical journals, but there really are 3 or 4, or maybe even 10, what are called truly preeminent journals, where publication in this journal really signifies good science. And so the studies that I'll be sharing with you come from these kind of big journals. So the first one that we'll talk about was published almost 10 years ago in a journal called Lancet, which is the British medical journal. And this was a meta-analysis. And what this group did is they combined several large trials that had been done in the years before, 10 to 15 years before, and they wanted to assess the question or to address the question, is aspirin beneficial and for whom? And when we talk about aspirin, there are two specific categories. Number one is prevention. So this is a person who's never had a heart attack, doesn't have heart disease, but is taking aspirin to prevent something. And then there's a second type of scenario where a person would take aspirin for what we call secondary prevention. Secondary prevention means a person has had, number one, a heart attack or a stroke. So there's a big difference taking aspirin for primary prevention, which is the bulk of our talk, or taking aspirin for secondary prevention, which is aspirin after you've been diagnosed with a heart attack or a stroke. So what this group did, as I said, they've combined several large trials together, and at the end of their analysis, what they said is this: aspirin has substantial overall benefit in secondary prevention, but in primary prevention, aspirin is of uncertain net value. So the message here is a person who has had a heart attack or a stroke most likely would benefit from an aspirin. A person who has not had an event like that, the benefit for them is questionable. Several years later, a different group of scientists combined 8 big trials together, and these trials involved patients who had been followed for up to 5 years. And what they said is, hey, maybe besides preventing heart disease, there's a signal here, there's some potential that maybe aspirin in these patients could reduce a risk of cancer. And so that was a very attractive idea, that maybe aspirin has a role in not only reducing heart attacks, but in reducing cancers as well. And so that led further to physicians prescribing or recommending aspirin even more widely, because we thought, hey, this is an older person, they probably have a reason to be on aspirin for heart protection, but maybe they should be on it anyways because it would be helpful for preventing a cancer. And so that's kind of that's the background. Okay, that's the background for the trials that were published in 2018. There were 3 large trials that were published last year, and all 3 of these trials were published in the New England Journal of Medicine. The New England Journal of Medicine is one of the most premier, most prestigious journals that we have in the medical world. And to be published there, you really have to have significant scientific impact, and that impact has to be validated by a lot of people who are very big in the fields of medicine and cardiology. And we're going to talk a little bit about each of these trials, but what is important to keep in mind is that these trials were truly what we call the gold standard trials in medical literature and in medical research. These trials were placebo-controlled trials and with patients who were randomized. These trials were very, very large. They were trials involving 15,000, 13,000, 19,000 patients. And so this isn't like anecdotal evidence or anecdotal, someone's commentary about something. This is kind of the best clinical evidence that one can gain from doing scientific research. Each trial addressed a slightly different population, and we'll talk about some of the peculiarities of each one and some of the specifics of each one. In total, what these trials showed, and I'm kind of giving you the preview, I'm giving you already what I will be giving you at the end, but ultimately what these trials showed that in total, the role of aspirin for primary prevention, meaning a person who does not have who has not had a heart attack or a stroke, the role of aspirin in this population should be very, very limited, should be very, very small. And so for that reason, you've had many physicians switching their patients off of aspirin, and you've had many patients asking their doctors or calling their doctors and saying, hey, should I come off given this literature? The overall medical consensus currently goes with this evidence, goes with this information, that given what we currently know and given the robustness of these trials, this is where we stand on aspirin. And one of the big publications or big guidelines that we have as cardiologists are guidelines that come from the American College of Cardiology and the American Heart Association. And so there were new guidelines that were published earlier this year from these organizations that already reflected this new data, that already said maybe someone should be on aspirin, but the role of aspirin should be really, really limited and should be highly targeted, specifically in very specific circumstances for very specific groups. Everyone is following? We're good? All right. So a couple things. I'm going to talk a little bit, I'll get a little bit deeper into these trials as we go along. The first trial that was published was called the Ascent. A lot of these really big trials, what's important to keep in mind is there were tens of thousands of patients in these trials. These trials were published where patients were gathered often across different countries. This is a big scientific effort to get this work done. And often these trials have names that are kind of catchy and that are easy to remember. So the first trial was called Ascend. So Ascend had 15,000 patients, and specifically what they wanted to do wasn't just to say, hey, anyone who needs aspirin can come into this trial. They specifically analyzed patients who were diabetic. Because for decades, and it still holds true, our understanding of diabetes is that this is a person that probably has an increased risk of developing heart disease or stroke. And so these are the people who would really stand to benefit potentially from aspirin. So this was a particularly useful population to study. And we'll get to the answer. But the question was, would aspirin be useful in this patient population who's already predisposed to risk, who would stand the most to benefit? The next trial that was published was called the ARRIVE trial. 13,000 patients were in that trial. And again, the trial is usually designed by a group of scientists, the steering committee. And here they wanted to select not simply all comers, but they wanted to select patients who already had evidence of increased risk for heart disease. So they were all moderate risk patients. Again, for the same purpose, saying, hey, these are people who could really stand to benefit from from this medicine. Would it be helpful for them or not? And then the last trial is called the Aspirin trial. 19,000 patients were enrolled. And here the question was much broader, healthy patients. Let's select people who generally don't have known heart disease or known risk factors. They selected people who were over 70 in Australia. In US, they used 65 as a cutoff. A nice part of this trial is that they also did a good job of recruiting minorities and to make the data more robust and to really answer the question broadly for a broad population. So what I'll show you on the next couple of graphs, you'll see. So these graphs, this is what is actually published in the journals, what is actually published in the literature, and it takes a little bit of time to understand how to read these. And what this is the trial where it was simply healthy elderly patients. There were over 19,000 patients. 9,500 patients got aspirin. 9,500 or over 9,500 patients got placebo. Placebo meaning it was simply a sugar pill. They knew that they were taking something, but there was no active ingredient in it. Majority of the patients were either over 70 or over 65. There was a significant number of African American and Hispanic patients from the US arm of the trial. And again, the goal was to really make a useful set of data that would really apply broadly to a wide population. And what these graphs show here is cumulative incidence of a primary composite endpoint over years since randomization. So what this means is, what is the chance of someone developing a heart attack or stroke or significant bleeding over time? And what you can see, and it's difficult to see, and that's part of the answer here, is that aspirin and placebo aspirin is in red and placebo is in blue. And here, as you can see, there's a line going up here. And the blue line is right over the red line. The two are completely interchangeable. They completely overlay one another. And what does that show? It shows that there was no difference in the reduction of death or heart attacks or strokes in the patients who were taking aspirin versus a placebo. So taking an aspirin really didn't do anything in terms of prevention. It didn't help. It didn't help at all. The patients followed the same curve. The same percentage of patients ended up developing those events as the patients who were taking a placebo. I'm sorry? So the study was published last year, but they had collected data for 5 years before publication. So I think the data stopped being collected in 2017. And so this is very current data. So these are patients who live in the current decade, and they followed patients for up to 6 years in this trial. And here, what they said, well, the hazard ratio, what is the risk associated with aspirin? And in this specific trial, the risks were very similar. You could see there's a point at the end where aspirin was a little bit higher than placebo, but it was not statistically significant. These numbers here just indicate that the difference was not statistically significant. So with this trial, we said, hey, benefit of aspirin is probably not there, but the harm isn't clearly there either. What this trial showed, what was another useful part is, and I'll come back to this a couple times, is cancer. Could cancer have been avoided with aspirin? And as you could see, this is the first slide that I'm showing you where there's a separation. So here, the hazard, the concern of developing cancer was actually higher in the aspirin group than in the placebo group. It wasn't the main thrust of the paper. It wasn't the main takeaway, but at least it took away or began to chip away at the story of aspirin as a prevention for cancer. So even if the data wasn't specifically designed to analyze this piece, the researchers felt quite confident that say, hey, in terms of prevention, this is probably not going to be useful as a preventative tool. And then earlier this year, there was a group of scientists who published this paper. And this paper specifically analyzed these three prior trials that I shared with you, and the risks, the benefits, and the harms of the trial. And what is the takeaway? And I'll share some kind of deeper knowledge with you in terms of the way we look at statistics. What the paper was analyzed, and so this was an example of a meta-analysis like I shared with you before, except the benefit of this paper was that it was a meta-analysis that now included these three really respectable, really large trials that were tried to answer the question very definitively. And what did they say? They say that if you take aspirin, the risk of cardiovascular event decreases by 11%, but the number of patients you need to give aspirin to is 265. So that means that if I'm in the office, I would need to give aspirin to 265 patients to minimize the risk of an event by 11%. So the number needed to treat was 265. And for perspective, that's a pretty high number that you would need to treat. We think about population-wide, so we think about good or harm when we prescribe this medicine to tens of thousands of patients. But usually the medicines that we prescribe have a number needed to treat of 30 to 40. So we need to give, for example, lisinopril or another type of blood pressure medication to 30 or 40 patients before one of them will actually live on to experience the benefit. But what was significant here in this meta-analysis is the incidence of bleeding that was found in these trials of patients receiving aspirin. So there was an increase of major bleeding by 43% compared to placebo. And the number needed to harm was 210. So you would need to give aspirin to just 216 patients before you develop an adverse event. And so the benefits of aspirin, there are some. Yes, aspirin does reduce the risk of stroke and does reduce the risk of a heart attack, but the harm outweighs it and at least balances it out. So that's the current understanding. That's where we are with aspirin for primary prevention. I take this time again to emphasize that we're talking about aspirin in the setting of primary prevention. So don't take this data, and I'm making it kind of very gloomy, but don't take this data to say, like, I'm going to stop taking my aspirin. That should be definitely a conversation that you have with your physician or with your cardiologist. If you have had a stent, or if you've had a heart attack, or if you've had a stroke, currently the evidence shows that you should continue aspirin. You should continue aspirin because in your case, or not in your individual case, but a population as a whole, in those people, the benefit of preventing another heart attack seems to be outweighing the risk of a bleed. But for a person who's never had a heart attack, the risk of a heart attack is low enough that the bleeding becomes a more significant concern.
Can I ask you a question?
Yes.
Was there a difference in the dosage of aspirin?
No. So all of these patients, and that's a great question. So all of these patients received what we call a baby dose of aspirin. In America, it's 81 milligrams. In other countries in Europe, it's 100 milligrams. So that itself is not as significant, but it was all patients who received low-dose aspirin, 81 to 100 milligrams.
Was there any correlation with taking a high dose?
All of these patients, I'll answer that, I'll get back to that at the end, but all of these patients were receiving 81 to 100 milligrams, which is considered a low dose. We'll talk about, I'll answer it later on, but full dose is 325. Yeah. That wasn't trialed in these patients. So next I wanted to talk about, to move beyond aspirin, to talk about a few of the supplements that people have been using recently and also has been recommended recently that I think would be useful for people to know and to kind of begin to understand. So there was a very large national survey that was conducted from 1999 through 2012 throughout it was a very broad survey of the United States, and it showed that more than half of the adults in the US consumed dietary supplements. It's a huge, huge business. It's a huge, huge industry. And very often people take the, dietary supplements because they look at it as a relatively harmless idea. You know, it's not a medication. It probably doesn't have it's not regulated like medications are. Maybe there's no risk or less risk than a regular medication. So people take supplements very widely in America because we kind of want to believe that there's something that we can take to better our health that doesn't come at a big price. In the past decade, the number of persons who supplemented their diets with fish oil increased by a factor of 10. So fish oil, it's been really, really widely spread in the popular media as a benefit, as a good and healthy thing. And so the next couple things I'll share with you deals with that specific idea. And the question here was, does fish oil help patients? Does fish oil supplementation rather help patients? So a little bit of background, or just so that we have a little bit deeper understanding of what do we mean by fish oils, why is it significant, what's the idea. When we talk about fish oil, what we're talking about are omega-3 fatty acids. It's a type of fat that is found in fish oil. And the idea is here that our body can make most of the types of fats that it needs from other raw materials, other fats, other sources of other nutrition that we intake. There are specific types of fats that are called omega-3 fatty acids that our body cannot synthesize, cannot make on its own. These have to come from our diet. And omega-3 fatty acids are these essential fats, and the body can't make them. It must get them from food. Why is it so special? What's so special about these essential fatty acids? They're an integral part of the cell membranes throughout the body and affect the function of the cell receptors in these membranes. So all of our entire body is made up of millions and billions of tiny, tiny cells, and each one of those cells has fatty acids within them as part of their makeup. And they provide the starting point for making hormones that regulate blood clotting, contraction and relaxation of arterial walls, and inflammation. So they really are an integral part of our physiology, of our being. And so for that reason, the idea was, hey, these things are really important to us. Would we benefit from taking more of them in tablet form? There are three main types of omega-3 fatty acids, and hopefully this doesn't get too detailed here, but the idea, I think it's still useful for people to hear it. There are three types of essential fatty acids. One is called EPA. This is found in fish. Another one is called DHA. This is also found in fish. The third is called ALA, and it's more widely available in vegetable oils, nuts, flaxseed oil, leafy vegetables, some animal fat. And this type of fat, ALA, is really used for our energy needs. So when we are working out, when we're living a regular life, when we're moving, when we're thinking, when we're writing, when we're speaking, this is for all of our metabolic needs. This is the form that's usually used. It's important, and I hope this doesn't get too narrow here, but it will affect some of the potential conversations that you may have with your physicians. EPA is a type of fish oil that lowers triglycerides, which is a type of cholesterol that your doctor often checks when they check your cholesterol. And it does not have an effect on LDL. So we call it LDL neutral, meaning that taking this fish oil can have some beneficial reduction in your triglycerides, but the bad cholesterol, at least the number, stays neutral, is normal, is not affected. There's another type of fish oil called DHA. It lowers triglycerides as well, but it seems to raise LDL. It's still not known in medicine whether this is a significant finding, whether this truly negates the effects of fish oil, but it's important to keep in mind that oftentimes when a person starts taking fish oil, it may be that a doctor had prescribed it for a specific purpose, but often you can see that certain markers that we check for in cholesterol are raising in a direction that you don't want it to be raising. And that just means we have to have a more nuanced understanding and a more nuanced approach of the treatments. Next, what I'm showing you are two trials. these are graphs from 2 trials, and one of these trials you have already heard of. I've mentioned this trial called Ascend. These are patients with diabetes. And another trial I haven't mentioned yet, it was called the VITAL trial, and it was published much more recently. What both of these trials did is they used a medication called Lovaza, which is essentially purified fish oil, and it comes with large proportions of 2 of those fatty acids that I said come from fish. So it had 460 milligrams of EPA, it had 380 milligrams of DHA. So together, the patient received 1 milligram tablet of highly purified fish oil. And the idea was, does taking fish oil supplementation, does it prevent cardiovascular events? Does it prevent stroke or heart attacks? And the answer essentially is no. It did not show to have any beneficial effect on prevention of heart attacks or strokes. Here, it's very difficult to see. It's very difficult to see any separation here in terms of cumulative incidence, and the reason for it is because there was no difference between the 2, so the 2 lines overlay each other. And here, you could see the lines separate a little bit as time goes on. For hazard, could there be any risk with taking fish oil? But even though we see the separation visually, statistically it was not a significant difference. So there was no risk or benefit for taking fish oil that was found in the VITAL study. And VITAL, I'll share with you, this was also a really large trial with tens of thousands of patients enrolled. And the Ascend trial I've already shown to you, but essentially the data was the same. You could see the line, it literally looks just like one line because there was no difference in the data. And these 2 lines separate a little bit towards the end, but statistically they were the same. So there was no difference in cardiovascular outcomes with low-dose fish oil supplementation. Okay. And these results indicate that supplementation with omega-3 fatty acids at a dose of 1 gram per day was not effective for primary prevention of cardiovascular events or cancer events among healthy middle-aged men and women with over 5 years of follow-up. So that's a significant piece of data. This was one of the largest trials ever done on this topic. The patients were followed for 5 years, which often is enough time to begin to see some of the potential benefits that may come from the medicine, and nothing was being shown or being seen at the end of those 5 years. There's a lot of nuance. This is a large trial with a lot of data points, and I'm only giving really the big takeaway points, but there's a lot of nuance. There's a lot of ways to dissect the data. These are thousands of patients, when there's thousands of ways to try to angle the question and look for different possibilities within the data. But the overall takeaway was that supplementing with fish oil for primary prevention, again, we're talking about people who have not had a heart attack or stroke, does not seem to be beneficial. We'll do the questions at the end. Next, I wanted to talk about vitamin D. Vitamin D is another kind of part of medicine that has been just integrated. Our physicians often check for vitamin D, and vitamin D levels are important, and we follow them and we take supplementation. And why is vitamin D important? What is vitamin D, and why is it significant? Well, vitamin D is prescribed to prevent and treat bone-related disorders. So it's an integral part of bone metabolism and bone health. There were previously, over several years, there were a lot of observational data that suggested that lower levels of vitamin D were associated with higher risks of cancer and cardiovascular disease. So a couple things here. These are observational data. What that means is these weren't trials like the ones I discussed with you, have been discussing so far, where you take a group of population, you give them X, you give them Y, and you see if their benefit is their harm. Observational data works in a completely different way. Observational data simply says, hey, I'm going to study this segment of the population. You say, hey, these people have lower levels of vitamin D, and they seem to have higher risk of cancer and heart disease. This type of analysis does not establish the cause or effect. It simply says, it establishes correlation. So one of the things that you may have heard in science of this idea of correlation and causation. So just because something seems to be true in a population doesn't mean that that we know what the explanation is for that specific finding. So this was kind of data that was essentially less superior than what I've been sharing before, that said, hey, maybe there's something here. And that those studies then prompted these larger trials. Active vitamin D was in the lab was shown to suppress cell proliferation in vitro. And the question was, well, maybe maybe in a human body, it would be useful to suppress cell activity, meaning could it be useful as a cancer medication? Because it was useful in the laboratory, in the petri dish, or in mice. And to answer this question, this vital trial was done. Vital, I've mentioned before, because Vital addressed two questions. It addressed the question of omega-3 fatty acid supplementation, and it also addressed the question of vitamin D supplementation. And so this is a trial that had over 25,000 patients enrolled in it. Patients, there was, as I shared before, there were African American patients. Patients were over 50 years old for men, over 55 years for women. Patients received 2,000 units of vitamin D per day versus placebo, and patients were followed for over 5 years. So again, the trial was robust in terms of how many people were in it. The trial was robust in terms of how long the patients were followed. And the trial was robust in the way it was conducted, that these patients were truly randomized, meaning two groups were exactly the same, minus with the only change being whether they received vitamin D or not. And what did we see? We see another graph similar to the ones that I've been showing you, where the two lines are essentially indistinguishable. The two lines are essentially interchangeable, meaning the cumulative incidence of cancer of any type here is exactly the same. So there was no decrease in cancer with the medication. The hazard, again, the hazard was essentially unchanged. There was no harm that was caused by supplementation. Of placebo versus vitamin D. Major cardiovascular events. We've talked about this before. There was no difference in these trials with regard to cardiovascular events. Meaning vitamin D did not improve cardiovascular outcomes. So we should not be taking vitamin D to try to improve these events. So the question is, well, what can we do? I just showed you that aspirin for primary prevention is not recommended. I just have shown you that eating supplements of fish oil is not helpful. And I've also shared that vitamin D is not very helpful. So the question is, well, what are we left with? And the truth is, we're left with the basics that we've known about for decades, and the basics is the hard work. And the hard work comes in the form of diet, and comes in meaning watching what we eat, being selective about what we eat, and exercise, dedicated cardiovascular exercise. So that's truly what we have in our armamentarium to make us live longer and to make us live better, hopefully. So the most important way to prevent atherosclerotic vascular disease, heart failure, or dangerous types of arrhythmias like atrial fibrillation is to practice a healthy lifestyle throughout life. It means this is work that we are dedicated to and are focused on for years, truly for years. We're approaching the end here. There's an important calculator that we often use in the clinic, and that you can ask your primary care provider or your cardiologist about the risk. And there's a specific risk calculator called the ASCVD, atherosclerotic cardiovascular disease predictor, over 10 years. And so this is a specific calculator that we can use for patients who are 40 to 75, where you plug in the gender, plug in age, you plug in blood pressure values, you plug in cholesterol values, and the result indicates a person's risk of developing an event over the next 10 years. And depending on how elevated that number is, that will inform the treatment plan between you and the physician. Meaning, do you need to be on a cholesterol-lowering medication like statin? Maybe the number is so high that maybe you're the rare person for whom even aspirin may be recommended. And that's the beginning of a conversation and the beginning of assessment of a person's risk of developing heart disease. So in the current guidelines from the American Heart Association and the College of Cardiology, American College of Cardiology, it's highly recommended that this be part of your physician visit, and this is part of the conversation that you have. Next is diet. For sure, diet matters. There's no question about it, period. A diet emphasizing of intake of vegetables, fruits, beans, nuts, whole grains, fish is recommended to decrease risk of developing heart disease. What I've shared with you about fish oil is fish oil supplementation, meaning fish oil that you take, in a capsule. It does not mean that fish shouldn't be eaten. Fish is very, very healthy, and it's pretty clear that deriving those fatty acids from your diet from fish does have beneficial effects and does have beneficial outcomes. So for sure, we should be eating fish and plenty of it. We should be eating fresh fruits, vegetables, and minimizing cookies, cakes, candy, all kinds of simple carbohydrates and processed foods.
Doctor, any kind of fish?
We'll get into it. I'll get into it. The other thing that's significant is weight, is maintaining healthy weight. So every time you go to the doctor's office, they take your weight. Usually your height doesn't change too much. At some point it may decrease, but what we care about is this metric called the BMI, the body mass index. And that's what we use to assess if someone is, number one, overweight, or if they are obese, and how much so are they. And the idea is, it is very clear through the literature, through the science that's been done for decades now, that maintaining normal weight matters. It matters when you're young, it matters when you're middle-aged, it matters as you age. The benefits continue to be there. There is no age at which it stops being beneficial to be closer to normal weight. Further, if someone begins at a higher weight, losing 5% of that excess weight is clearly beneficial. There's a significant reduction in blood pressure, in bad cholesterol, and glucose, and high glucose levels. So the question I'm often asked, and I think this is my last slide, the question I'm often asked in the office is, okay, well, you told me to do exercise. What are some specifics? Give me some specifics. So the specific number is 150. That means 150 minutes per week of moderate intensity exercise. This is dedicated cardiovascular exercise. So the stuff you do around the house to live, the stuff you do as part of regular daily life doesn't count towards this. This is dedicated cardiovascular exercise. If you come here, you go to the gym. If you come here and you do an aerobics class, if you do whatever you enjoy doing physically, all of it is fine. There's no one exercise that is needed, but it's 150 minutes of dedicated cardiovascular exercise where you're huffing, puffing, sweating, getting your heart rate going. And the way you do it, it's completely up to you. You can do 5 days a week of 30 minutes. You can do 4 days a week of 40 minutes. Whatever makes sense. But that's the guidelines. And the data also backs up this number. This number is recommended not only by the American College of Cardiology, the American Heart Association, but also by the World Health Organization. And there's clear studies that have shown that with this number, there's significant benefit in terms of reducing rates of heart failure and reducing rates and the risk of heart attacks. That's it. So I'll take questions now. I've given you a lot of data, so it may take time, but I'm open.
Prophylactics, I understand, is not very important. After effect, as secondary, you didn't talk about it.
I didn't. It's impossible. I didn't even talk about all of the, we just covered it in very broad details. The first part, the primary prevention. It's a huge, it's two or more talks to discuss about things that we can do for secondary prevention. At this point, What we know is this: a person who has had a stroke or heart attack, number one, must be on a cholesterol-lowering medication, must be on a statin. So there should be a good reason in discussion between you and your physician if you're not being on one, because the breadth of and the weight of the evidence says that you should be on one. Second, and probably aspirin as well. Most likely a person who's had a heart attack and has had a stroke, they need to be on aspirin. That's the current guidelines. Each person's situation is unique, but that's the initial assumption should be those two things. It's the statin, the cholesterol-lowering medication, that gives us the most value so far. What we know is that that will give you the most value in terms of preventing another event.
If you've had a couple of mini strokes, is that considered, should you be on?
So mini strokes, people use the word mini stroke in kind of loose terms, and sometimes it's we use words to make it simpler for patients to understand, but sometimes that ends up kind of muddying the waters. Most likely, most often, when a physician uses the words mini strokes, what a person has had is what we call a TIA, a transient ischemic attack, which means it was a stroke. It was completely a real stroke, but thankfully the brain regained its blood supply, and the person didn't have a consequence of this, sequela of this. And the idea currently is that if a person has had many strokes, we treat it as if they had a regular stroke. So they would be on aspirin and they would be on a statin. Correct.
When people take Coumadin, it makes more side effects taking aspirin, they can take together?
So the question is about Coumadin. Coumadin it'll be difficult for me to answer it because it just takes us in a completely different direction. Coumadin is a very, very potent blood thinner. There should be a very specific and clear reason and indication for being on it. Aspirin is a blood thinner as well. Together, the risk of bleeding is higher. But there are many circumstances where in clinical situations it makes sense to be on both. And I have many patients who are on both. It can combine. But it's important to understand clearly, why are you doing it? What is the clear indication for aspirin? And what is the clear indication for Coumadin? So this needs to be a very purposeful decision that is made. But it's not always that they're contradictory. You may have to be on both, but it has to come purposefully.
As a herbalist, I wanted to remind us about another benefits of supplements. Omega-3 that works for inflammation, let's say, and be connected connected to both.
Yeah. So
and this is still next test.
Trial. So the question is, vitamin D for bone health. Absolutely, the levels should be checked, and if your levels of vitamin D are low, absolutely, it should be supplemented. It's not healthy to have low levels of vitamin D. Most of the patients in this trial for whom vitamin D didn't provide cardiovascular benefit, most of the patients actually had high levels of vitamin D, higher than average even. So you can be argued, well, these patients have already had good levels, maybe that's why they didn't get a benefit. So there's completely a role for vitamin D in medical care. Don't take it in another way. What the trial simply showed is that additional vitamin D level for the purpose of reducing heart attacks did not seem to have that effect.
When you think about heart attack or stroke, I've had neither, but I have angina. But one those still need to take aspirin, etc.
A great question. So the question is about angina. A person who has not had a heart attack or stroke. That is probably the scenario where it should be an individual decision. The angina we often use it as a general term. It simply means chest pain. But we should try to understand, why is a person having chest pain? Is there significant heart disease that is actually impeding the flow of blood? And a person who has that much heart disease where blood flow is impeded, maybe they would benefit from aspirin because the risk of having another event is just so high. So that one would be a more targeted discussion, a more targeted evaluation.
You showed a slide that said that daily aspirin reduces cancer risk by 44%, and another one that says that it increases it. So,
yeah, so very good. So that's a very fair question. So what's important to keep in mind is that the slide that I showed where there was a reduction of cancer, that was a trial that was a study not from primary analysis of a randomized placebo-controlled trial, which is one of those three that I shared with you. That was a meta-analysis. And so often meta-analysis and that data was taken as what we call hypothesis generating. So there was this signal, there was this information, but we really look for these large trials that are randomized, controlled, placebo-controlled trials that then give us the final word. So the current answer is no, there's no benefit of cancer risk. That's, again, everything, there's caveats. Maybe in 20 years we'll have a different set of information, but as is, currently, there's no role of aspirin for cancer prevention.
I would like to ask you about vitamins. I take one a day vitamin for women. Is still advisable to take the vitamin D and fish oil?
So the question is vitamin supplementation as a whole. Overall, by the medical community, there is not a clear benefit and there's not a clear recommendation for daily vitamin supplementation. If a person is deficient in specific vitamins or a person's diet doesn't provide them with specific vitamins, then they should supplement those vitamins. But there hasn't been clear benefit or clear data that daily vitamin supplementation, like Ultim or once a day men's or women's vitamin supplementation provides them with benefit.
Thank you.
Is having a high level of vitamin D harmful?
If it's very high, it needs to be followed with your physician. But overall, a healthy level of vitamin D is healthy. So there's no, from the data that I've shared, there is no clear harm from vitamin D. What the data showed was simply that taking extra vitamin D on top of normal levels provided no benefit for patients.
Because tests shows that you have excess vitamin D. What is the problem?
That needs to be taken with your physician because that all kinds of derangements. The vitamin D it's a complex system of cascade of the way it's synthesized in your body. So that would need to be.
I've just been told to decrease my vitamin D. I don't know how to do that.
So you would probably take less of the supplement if you had been taking one before.
Would any of your studies that you mentioned, the three major studies, do they include differential among the participants in hypertension or weight, BMI? Did they put those in categories? Because it seems as though we're told that if you have a higher BMI, you are a higher risk for either of those two, or if you have a high hypertension, you have a higher risk too. So did they include that?
So the trials, having enrolled tens of thousands of patients, had a broad spread of patients with various BMIs. What happens is, as you drill down into specific BMI subsets, you lose more. You're now dealing with smaller and smaller population by definition, right? You're dealing with smaller segments, and with that, a lot of the statistical power of the studies then diminishes. Then they're not able to answer the question that they wanted to. I don't know what the average BMI was in the trial participants, but I'm assuming that it was representative of a broader society. Exactly. Having a higher BMI by itself should not be a big enough risk that you should start taking aspirin for prevention. A high BMI is unhealthy. It does correlate with higher risk of developing heart attack or stroke, but it should not be taken as a surrogate marker that, hey, this is a person that needs aspirin.
They say that older people suffer from osteoporosis, which is a low calcium level, etc. What is this business with growing all kind of lumps on my bones, and they call it arthritis?
Completely different. So the question was about.
Where is it coming from?
So the question was arthritis, osteoporosis. Completely different than our topic today. I wouldn't be able to answer, but it's a difficult question. All right, one more. Go ahead. I'll answer afterwards. Don't worry.
I was reading, I believe it was in the AARP magazine, some kind of a study that was done overseas, maybe Japan, that actually said that taking baby aspirin would increase cancer risks.
I'm not aware of that specific trial. Overall, there's really no clear mechanistic correlation. You know, we never were really able to show clinically on a molecular level why would aspirin even be a good idea for people with why would aspirin be a good idea to prevent cancer. There isn't really a clear link. A lot of those initial studies were observational data, as I was saying, where it was just simply a kind of a very broad analysis of people where you look for various correlations. It's these trials that more definitively answer the question of no, there is no benefit in terms of taking aspirin, in terms of reducing it. So clearly it wasn't reduced, and in one of the trials it was shown to be increased as well, which I shared as well, where there was an increase in cancer in one of these trials, but that specific one I'm not aware of. All right, we'll wrap it up. I'll stay and I'll answer questions. All right, thank you guys.